The line of incision of the transverse upper laparotomy is curved and placed under the costal arch. It can be shortened medially or extended laterally according to the required exposure. The subcutaneous tissue is dissected with electrocautery until the anterior rectus sheath is reached. In this film, we start the incision of the anterior rectus sheath in the midline, at the level of the linea alba. Here, an overview is shown of the subcutaneous tissue, the anterior rectus sheath, and the rectus muscle. Transection of the rectus muscle is performed. The superior epigastric artery and vein should be identified and, if required, ligated separately. These structures are not shown in this film. The aponeurosis of the external oblique muscle is incised lateral to the anterior rectus sheath. The subcutaneous tissue, the anterior rectus sheath, the rectus muscle, and the preperitoneal fat below the transected linea alba. The other muscle layers, consisting of the internal oblique and transverse abdominal muscle, are dissected here. The posterior rectus sheath should be incised. Take care not to damage the posterior bowel by lifting the posterior rectus sheath and peritoneum with forceps. The posterior rectus sheath and the peritoneum can be confluent, as shown here, and are cut simultaneously. The incision of the posterior rectus sheath is continued to the left side, leaving the round ligament to the liver intact. The peritoneum lateral to the round ligament is opened. The important structures here are subcutaneous fat tissue, the anterior rectus sheath and the linea alba, the rectus muscle, and ligamentum teres hepatis. Slowly absorbable continuous sutures are used to close the peritoneum and the posterior rectus sheath. This is the greater omentum, in perspective to the posterior rectus sheath. The transverse abdominal and the internal oblique muscle are lateral to the rectus muscle and are closed in one layer. The transversely opened anterior rectus sheath is closed. It isn't necessary to close the subcutaneous fat in the midline. The closure of the skin is not shown in this film. The skin is closed, preferably with a running subcuticular absorbable monofilament suture.